McInerney from Croaky here at the International Medical Regulation Conference, and I'm talking to Heidi Oetter from the College of Physicians and Surgeons of British Columbia. And you're going to just give me a bit of an update on the regulatory issues that are on the agenda in Canada at the moment, which we didn't talk about as we began, but including the High Court's decision on assisted suicide. For physicians, that's a big issue. So could you just give us a bit of a wrap on what the important issues are?
Well, certainly in Canada we are dealing with physician-assisted dying, except we've moved to the term medical assistance in dying to recognize that it's not just a physician act. It also includes nurse practitioners and obviously assisted by pharmacists, and we've spent much of the last year really looking at developing professional standards that encompass compliance with the existing legislation, as well as ethical and professional expectations of physicians who are either going to be involved in it, or if they're going to be conscientious objectors, what they are still expected to provide. We've been very clear with physicians that even though they may have moral or other objections to providing assistance in dying, that they have an obligation to their patient to make sure that they have enough information to make an informed decision about their health care. So they can't tell them, I'm not going to talk to you about it. They actually have an ethical obligation to talk to their patients who are curious or would like to know more about it. We've said that they don't have to refer them, but they do need to assist their patient, and that may include transferring their care if that's considered appropriate. And most importantly, they must not abandon the patient, and they must not ask the patient to justify their belief or impose their own belief systems upon patients. It's really one about autonomy, information, informed consent, and choice.
How difficult a process has it been to implement and regulate?
Do you know, in the end, it hasn't been. And I have to say that in the province that I work in, which is kind of like a state here, equivalent in Australia, we actually had everybody come together. And it wasn't about being for or against medical assistance in dying. It was about what is the public interest, what does patient safety look like, and what kind of ethical and professional standards do we bring to that. And that included nursing, pharmacy, health authority, the actual service provider sector, and as well as our Ministry of Health. So really in a short period of time we managed to get together a provincial program. Health authorities arranged patient navigators, the regulators talked about ethical and professional obligations, the ministry put together the forms, brought in the appropriate enabling legislation. We have the coroner's service providing the oversight, so we kind of got it right in a short period of time.
And in a period of some political instability too.
Yes, there was that too, but it was only a few years ago that we had a similar court case in Canada that the Supreme Court said no. This will be the biggest social change that I will see in my lifetime. And these big changes in social policy, public policy, don't come around very often, and this is one of them. And so far, I think we've managed to navigate that regulatory transition quite seamlessly.
Another one that we talked about is around Indigenous health, and of course it's a big issue in Canada as it is in Australia. And I'm just wondering about the role of regulation there, particularly around, if regulation is about providing patient safety, where does cultural safety come in?
Yeah, certainly the concept of cultural competency, cultural humility, providing culturally safe care is an emerging concept. And I'm pleased to say that in our province, one of our bodies has put together a cultural competency program. We were approached as regulators, all the health regulators, nursing, medicine, pharmacy, and the like, to make that training mandatory for our practitioners. And we're not really in a position to make it legally mandatory for everybody, but we certainly have the ability to impose that kind of training on physicians if they are found wanting in a complaint that comes to the college that they have been culturally inappropriate dealing with a patient who identifies as Indigenous, Métis, or Aboriginal, Inuit. But we are really encouraging physicians to take the cultural training program, and what we've done is we've actually included in our annual renewal of licensure form. So we ask physicians just to declare if they've taken the course or not, and we are going to be tracking that year over year and reporting it to the Centre for Excellence in Aboriginal Health to do what we can to be part of the solution and encouraging providers to be culturally competent.
You said there was the Truth and Reconciliation Commission has done some guiding work for you.
Yeah, there were actually 2 recommendations out of our Truth and Reconciliation report that was issued a couple of years ago. One was that we needed to encourage more First Nations individuals to pursue careers in medicine and nursing. It's hard to know how we as regulators contribute to that, but we would like to say that we're not standing in the way of that, and we know that our own training institution at UBC does have an Aboriginal track, and they are certainly encouraging individuals to pursue either training in medicine or nursing as Aboriginal people. The other one was to encourage more cultural training, and we've got that resource available, and we continue to try and encourage physicians to be part of that. So it's something we keep putting into our news bulletin that we send out to physicians. We've also made it a component of our training that we bring in for internationally educated physicians who are coming into British Columbia to work for the first time.
You also said, though, that Indigenous complaint levels are not very high.
No, and like many groups of people, we kind of look and say, why don't we see more complaints? Whether that's the geriatric population, the new to Canada population, the Aboriginal population. It's the old story. We think that the people who are better educated and better read are probably the ones that we hear from, and so it's how do we create those links? And it's something that we are working with our First Nations Health Authority. We're the first province in Canada to actually have a First Nations Health Authority that's responsible for the mostly secondary services to their citizens. We try to work with them quite closely, doing what we can, even though we're in the regulatory business, not the health service business, to try and improve what we can for the Aboriginal citizens of British Columbia.
Yesterday there was an example, there was a Canadian example as part of the case studies of really regulatory nightmare. What are other issues in Canada at the moment, and how do you think it actually is rating in terms of regulation?
You know, I think Canada's probably been a bit of a leader in terms of regulation. We've had a long history of having public or community representatives on our boards. We've always had, I think, very strong regulatory tools within our existing legislation, but that's why coming to conferences like this is so important. There's not very many of us who do this kind of work, and it's really important that we hear what others are doing, hear what other failures have been, as well as others' opportunities to do better.
What's been the best thing you've heard?
I think some of the stuff about risk regulation and focusing on that and thinking about how we can use our respective data sources to do a better job, I think that's really interesting opportunities.
Yeah, that's interesting. I was thinking when you were talking about Indigenous patient care, that could fit very much in that risk regulatory environment. Getting out there,
which is probably a little about doing a lot more listening.
Yes. Great to talk to you, Heidi. Thank you very much.
Thank you.